Good evening, everyone. Welcome to the next classroom session hosted by Spice Route India. So this session is special again. This is being conducted by the state of Rajasthan. It's the first time that Rajasthan state chapter is taking part in this session. And another specialty is that Dr. Esther, she's the Diploma family medicine student who is studying in the state of Rajasthan. So it's great that we have been able to bring all of them together and take this forward so that the diploma students can also be benefited and we can also interact with them in the best possible way. The other announcement I want to make today, I think it's the perfect time. Dr. Vishnu BS, he has been nominated as the National PG Coordinator. He will be leading the PG wing, wherein we will be interacting with maximum postgraduate students from the country and try and bring them together, hold sessions for them, academic sessions, and also clear their doubts and ultimately bring them under the AFPI banner. Dr. Vishnu, welcome and over to you.
Thank you, Dr. Jyotika. I hope I'm audible.
Yeah.
So welcome to the Spice Route India classroom for the month of April. So the month of April, we have a session being hosted by the Spice Route Rajasthan team. And first of all, I would like to welcome the president of AFPI Rajasthan, Dr. Arun Pradhan sir, to this meeting. And the moderators for today, we have two eminent academicians, Dr. Priya Charan, who is Assistant Professor, Department of Family Medicine at Mahatma Gandhi Institute of Medical Science, and Dr. Sujit Varghese, he is Pulmonologist at GMC Trivandrum. I hope you will have a wonderful session with both the panelists or moderators taking you through the session. And I would like to appreciate the efforts of Dr. Esther. She has done a pretty good job taking up the challenge of presenting the case presentation for today. And he is a Diploma Family Medicine resident at GMC Dholpur, Rajasthan. And I would like to welcome the senior teachers and all the other participants who have joined for this session. I would like to welcome Arun sir to say a few words before we move on to the session.
Good evening, everybody. Am I audible?
Yes, sir.
I am very glad to know that we are today having a academic session in Rajasthan and chapter of Rajasthan. I'm welcoming you to all of you behalf of Rajasthan, and I will congratulate to all students, PG students who are doing their work, and my sentiments with the DNB family medicine, because since 2010 I passed out the DNB family medicine, and it has to be increased in Rajasthan, and I'll try to have a separate department of family medicine in every medical college. So Bhilwara Medical College and Dholpur Medical College, they are doing PG seats right now. So I'm always welcome to all students to have them, and they can take my number. I'm always with you. To all of you, congratulations and thank you so much. Yes, Dr. Vishnu.
Yes, I think now we can move on to the presentation. I would invite the moderators to take the proceedings. Dr. Priya and Dr. Sujit, can you please take the proceedings from now on?
Dr. Esther, you can share your slides.
I think she's not able to share the slide. She should be made the co-host, I suppose. Dr. Jyotika?
Yeah, I just reset it. Yeah. Try again.
Can you make her co-host? Then only she will be able to share.
Sujit, Dr. Sujit and Dr. Priya, I think we can start this session. We can take over.
Yeah, we can start the session.
Dr. Esther.
We can see your slides. Hear you. Dr. Esther, please unmute yourself.
I think she is. Yes.
Can I start, ma'am?
Yes, yes.
So, good evening to all. I am a first year resident. So 2 months I was doing pediatrics and 2 months I did OB-GYN. Just now I came to medicine. So I was very interested to join medicine department because here there are no medicine residents. So we feel like our own department here in medicine. So can I start saying about the patient profile?
Yes, please start.
Sure, please start.
So in the female medical ward, I saw a patient and her name is Miss S, 20 years old. She was studying in 12th class and she is a resident from Rajasthan, Dholpur itself, in a village named Badi. She was admitted on 28th of March and we examined her on the same day. She had cough for 7 months and general weakness, decreased appetite for 7 months, fever with body aches for 7 days, difficulty in breathing and chest pain for 3 days. This was her chief complaints. Then history of preceding illness, 20 years old female, previously healthy. 7 months back, presented to us with complaint of cough, which was gradual onset, initially dry but productive since 1 week. Sputum was white jelly-like, amount was 1 to 2 spoonful. Cough had no diurnal or positional variation, no history of hemoptysis. She used to get relieved with cough syrups, but since a week, it has got very severe. She had fever along with cough 7 months back. She remembered it as August month. She was treated for the same at a primary health center at Badi village and started ATT on an empirical basis. Her cough and fever got better with the treatment. And then around October first week, her brother was informed about that she was infected with TB and was started on ATT. Then from her history, we didn't got a TB card. Her big brother gave history that her sputum was negative for TB bacillus and CB-NAT was also not done. But after that, she started eating less, became thin, and her clothes became more loose, improved. After a few months later on, after the treatment, she improved clinically, gained weight, and appetite also was improved. By the end of the March, she was having fever again. Fever was low grade with evening rise of temperature. It was not associated with chills and rigor. She had severe body pains since 1 week and feel feverish, which was relieved on paracetamol. Again, on admission, we checked her medicine. There was only five days medicines left, and we found that she was on drug-sensitive TB medications, which is category 1. She had no blurred vision at that time of examination, and since she was admitted before also at the time of ATT also, she had no blurred vision or changed vision. She had no nausea, vomiting. She had no complaints of yellowing of skin and eyes. Her bowel habits were normal, and she had no urinary symptoms. This was her drugs we found. Again, she had chest pain, which is more localized to mid-chest. It got severe while coughing, and increased pain was noticed on the line to right side. No pedal edema was noted. There was no radiating pain. There was no sweating. There was no palpitation, no throat pain, no abdominal pain or abdominal distension, no bloating or belching, no seizures, and no loss of consciousness, no history of trauma. For last 2 to 3 days, she was having shortness of breath. That's why she was taken to hospital. She was not able to walk upstairs. She had no orthopnea and no paroxysmal nocturnal dyspnea. On rest, she had discomfort in breathing first on the day of admission only. I finished present illness, history of presenting illness.
Yes, sir. Your presentation was good. Dr. Priya, do you want to comment first?
Yeah, actually, Esther, you made a good, and it was really good. I would just like to know, initially when you told cough, you have explained it everything. She had fever that time, then fever subsided, and it came back again for 1 week, I think.
Yes, ma'am.
And cough persisted all 7 months time?
All along the 7 months. But it
while she was on ATT also, that time also, correct?
That time also, yes, ma'am.
Recent symptoms were shortness of breath, fever, and chest pain, according to you.
Recently, the cough became expectorating, and also she started chest pain and also shortness of breath. That's why they came to hospital.
They came to hospital. So the cough, which was productive, was never blood tinged? No hemoptysis?
No hemoptysis, ma'am.
Never. And the weight loss, which you told, the generalized weakness, associated with fatigue and weight loss was?
Weight loss was like, since she is lean and thin only, but there was weight loss since 7 months. Like since 7 months, she lost only this much weight, only less weight only comparatively. It's not significant weight loss compared to her normal body weight.
Okay. Okay, correct. Let's go to the past history, whether she has an exposure.
I would like to add in the this segment, in the presenting complaint session. Can I?
Yes,
yeah,
yes, sir.
Sure. Yeah, can you please go to the presenting complaint slide? There are different methods of presenting a case, but different examiners will have their own ways, and I will sell some more compact way. I felt your presenting complaints as well as history of presenting complaints are as some more exhaustive. It was large and elaborate. We would have made it some more compact in some more, because in exam time you will get hardly 15 to 20 minutes to take up a case and present. So presenting such an elaborate case may be tough for you. So when you go to the presenting complaints, that slide, first slide, chief complaints, correct, chief complaints, good. Actually, if I was presenting, I would have made the cardinal symptoms of respiratory systems in the chief complaints, and all this general weakness, decreased appetite, everything in the associated symptoms in the history of the present.
Correct.
So ideally, the 5 cardinal symptoms of respiratory medicine are basically cough, breathlessness,
hemoptysis.
Good. Then
shortness of breath.
Okay.
Then hemoptysis and fever. Okay,
fever.
5 symptoms there. Some people add hoarseness of voice also with it, and fever will be outside. But I usually prefer fever also in the cardinal symptoms. Okay, so you can add as Cough 7 months. Okay. Fever, this body aches is not here. That can be included in the history of presenting complaint. So cough since 7 months, fever 7 days, breathlessness and chest pain 3 days.
3 days.
Okay. But if I was presenting, I would have included this initial, that 7-month thing would have been in the past history, or as just a single liner in the history of presenting. Come to the history of presenting illness. Your presentation was very good. You have taken a good history. If I was presenting, I would have presented like a 20-year-old female who was apparently normal 7 months back, who developed cough, chronic cough, and was diagnosed to have pulmonary tuberculosis. Now she presented with 3 days history of fever, 7 days history of fever, and the 3 days history of cough and breathlessness. So we will get the idea that this is basically a 20-year-old female with already diagnosed tuberculosis and was on treatment, and she developed something acute in the last 1 week. Okay. And when you explain this, the history of presenting illness, you explain each symptoms. So ideally that history in the 7 months back would have been avoided, or some examiners prefer that also in the history of presenting complaints. It's up to you. If it is that related, in this case it is related, so you can add like cough since 7 months. So each cardinal symptom should be explained in each heading. It includes onset, duration, diurnal variation, postural variation, aggravating factors, and relieving factors. So you should go like that. If it is cough, cough was chronic cough. It started since 7 months. It was initially non-productive, dry, later become productive. So if it is productive, you should say what is the quality of sputum, what is the order of sputum, is there any hemoptysis, like that. That expression should come. Then is there any postural variation is there? Is there any diurnal variation? So if the cough would, if you have told that there is diurnal variation of cough, we would have thought it is something airway disease like asthma or COPD like that. So since you didn't comment on any diurnal or postural variation, we can think it is something related to the infection. Okay, these are all pointing towards. So if we present a case, our aim is to come to a diagnosis based on all this history of the chief complaints and the presenting illness. So it should be focused on the diagnosis. So when you take a case, you should come to your own diagnosis in your head and go. You should present the case in such a way that you will lead to that diagnosis. You will make the examiner lead to the diagnosis which you have in your mind. Okay, yes, that's the way. So after cough, then you say fever 7 days. In fever, you should explain each thing. What was the type of fever? Then was there any aggravative? What was it relieved by antipyretics? Was there any evening rise? Was it associated with chills and all? Then breathlessness like that, and if there is hemoptysis like that, each symptom should have been explained in such a way. And this ATT history would have been better you included in the past history. Okay. Oh, you can go to the past history.
Past history, she had no history of any chronic illness before. She had short-term fevers before and was admitted in hospital 2 or 3 times, but none was more than a week hospital stay. No surgeries was done in the past. No history of traumas or injuries happened 1 week back. No history of any psychiatric illness. No history of any joint pains or swelling on any joints. No history of diabetes and hypertension.
Yeah, good. I would like to comment in the past history. Yeah. See, we always start with, is there any similar illness in the past? So since you have included the TB history also in the presenting complaint, you would have told there is no history of TB in childhood, or there is no history of TB in the past. So if the patient had a TB in the past, we could come at the diagnosis that the patient had a recurrent TB, relapse of the TB she already had. Okay, then you would have, since you are presenting basically a case with the respiratory symptoms, you should also comment that there is no history of any allergies in the past, no history suggestive of asthma, there is no history of recurrent cough or breathlessness in the past. Okay, that would have been some respiratory diagnosis. This cough, breathlessness, chest pain, and fever are basically point out to many diseases. So in past history, if you had told that if such symptoms are not there, we could again think that there is some infection rather than airway disease or any ILD or any childhood-related infections. So you should frame your past history in such a way that all the other diseases are ruled out. Okay, and I will say this history of trauma or okay, trauma is okay. This chest pain, so any psychiatric illnesses could have been avoided. The joint pain and swelling can be added. No history of diabetes, hypertension, and other history is good. Okay, go to the next.
In contact history, she has no COVID-19 context, but her father had said that, like she said to me that her father had tuberculosis in 2014, but he was absolutely well and healthy now. We didn't see the father, but she said us like that.
Is there any heading named this contact history in the usual case presentation?
I would like to comment on this, Dr. Sujit. Usually there is no. When we used to present cases, if I would have been there, there is no particular topic like contact history. And it can be added, it could have been said in the past history only or with the family history.
Family history, better.
So it would have come that father had tuberculosis 2014. It's better to get more information about father's tuberculosis history, whether he took treatment, how the diagnosis was made, where he stayed in the same house, whether precautions were taken or not, whether he completed his course. These all should be included. If you say somebody had tuberculosis in the family and people were living around him.
Okay, ma'am.
Close contact, parents having tuberculosis and kids staying. So definitely.
Yes, ma'am. Can I continue, ma'am?
Yes, please.
Now we'll go on to medicine history. She is presently on ATT. No history of allergies to any drugs till now. No history of blood transfusion in the past. This is her medicine history.
Okay.
Personal history.
Esther, just to ask, is there any importance of asking blood transfusions? How did it come to your mind to ask about blood transfusion history? Allergies, I completely agree. Respiratory case and allergies go parallel. That's okay. And
Yes,
drug, something we have to ask. That's okay. What Dr. Sujit mentioned, allergy is the foremost thing we should ask during the past history. But blood transfusions, I don't know. Okay, let's continue.
Personal history is vegetarian diet.
Yeah, that's. I would go with what Dr. Priya had taught. So unnecessarily, you should not put any points for the examiner to catch you.
Yeah, that's what, because everything you put, they will ask.
Yeah, all irrelevant things should be avoided.
Yes.
Better only focus to the case or focus to the diagnosis. You say.
Don't give them chance to dig you more and more.
Yeah. There should be many positive history and also.
Yes.
In personal history, she's a vegetarian, and she told about irregular sleep patterns and with loss of appetite and weight since long time, not habituated to smoking or alcohol.
Okay, so, Dr. Esther? Yeah, here I just want to ask, irregular sleep pattern was because of what? The cough bouts irritated her? Was there any cough disturbing? Was there any breathing difficulty? Or what was the alteration in sleeping pattern?
She said that since she got this disease onwards, she had this anxiousness, more anxious, and also she was not eating also because of that. And the cough was a long time disturbances for her all through the disease period.
Okay.
You include 4 things. You have include all the 4 things. Basically, we need to
bowel, bladder,
personal history. Yeah, diet, appetite, sleep, bowel, bladder, and addictions. So include everything.
Correct.
Okay, sir. This
mention
was
about the bowel bladder next time. Whenever you take a personal history, mention about bowel and bladder habits.
Yes, ma'am. This was their family history pedigree. She was the third child in their family, female child.
Okay.
And according to Kupaswamy scale, the scoring for the socioeconomic status was 15, and it falls under lower middle class.
Okay.
Her father was a farmer and illiterate, and their salary scale was less than like 2,000 per month. So it comes under this, ma'am.
Okay.
So you should, there will be a common question when you present this. They will ask what is overcrowding.
Yeah. Correct.
Okay. You should say how many people in different square feet. You should have that idea about, that's a common question being asked, especially in a case which has tuberculosis has a diagnosis. You should know what is the, whether it is a kacha house or a pakka house, how many people are living in the house. Was there any overcrowding? Everything you should mention. Okay. Right.
Because 9 people staying under one roof.
One roof.
Class. And of course, father had tuberculosis. So many questions arises among this.
Everyone should know the definition of overcrowding. That's a big answer. That's why I'm not answering. Okay. There's a very big answer for that. You should be well aware when an examiner asks, especially exam going students should know what is overcrowding. Okay.
Yeah.
And Kupaswamy scale. That good that she mentioned Kupaswamy scale here. That modified Kupaswamy scale should be used. You should have an idea what all parameters are there.
Okay, sir. About her menstrual history, menstrual cycle was regular with average blood flow of 2 to 3 days. She used around 3 to 4 sanitary pads a day. Her LMP was 23,323 and she was unmarried. Psychological history. At the time of admission, patient was anxious. She was not found very active and was always reluctant to take any medications. Her brother told she always felt sad about having diagnosed with this illness and was never counseled by anybody. That's why I included psychiatric illness, sir.
Okay.
History of presenting illness summarized. 20-year-old lady who was diagnosed as pulmocox, who was on ATT therapy, started by October 2nd. Currently presented with gradual onset low grade of fever of 7 days duration and was associated with cough, chest pain for last 3 days and later with a severe shortness of breath on the day of admission.
Okay. See, when you say avoid that term COX, try to put diagnosed as microbiologically confirmed or clinically diagnosed TB. So now we have, what is the National Tuberculosis Guidelines called now? What is it?
I don't know, sir.
It was earlier RNDCP, Revised National Tuberculosis Control Program. Now, what is it? Now it is NTP, National Tuberculosis Elimination Program. So we all follow this National Tuberculosis Elimination Program now. So the TB is basically of 2 types. We can classify accordingly. So if you diagnose the TB, it is basically 2 types. One is the microbiologically confirmed TB. Microbiologically confirmed TB means it is confirmed by any of the any sputum investigation or histopathology examination or microbiological diagnosis. It should be there. And try to use a term, the correct term, pulmonary tuberculosis. Okay. And include ATT therapy under National Tuberculosis Elimination Program guidelines from October 2nd. You can include whether the patient was in intensive phase or the continuation phase. So we'll get more idea. Okay, how many months of treatment completed. So with this history of presenting illness, what is your differential diagnosis right now? What are the differential diagnoses you have right now?
The patient had a severe shortness of breath at the time of admission, and she had low-grade fever also.
Avoid the term severe shortness of breath, I will say. So the breathlessness or shortness of breath should be graded. There are standard ways of grading breathlessness. What are the ways of grading breathlessness? Tell at least two parameters to grade.
Respiratory things are graded by MMRC.
Good.
And cardiac causes are graded by NYHA classification.
Excellent. At least 2 you should know. There are many others. Borg scale, pain index, visual analog scale, St. John's questionnaire. Many things are there. You should know at least 2. That is MMRC and NYHA. And if any examiner asks what you grade MMRC, you should be able to say it very easily. Okay, so you should say whether it is grade, the severe, you might have included grade 3 or grade 4 breathlessness. So say MMRC grade 4 breathlessness or breathlessness of grade MMRC grade 2 or 3. Fine. So with this, yeah, with this, what are the differential diagnoses we have?
So I had first time when I had the physical examination, I was thinking about.
Don't go to physical exam. Don't go to physical examination with this presenting complaints. With this much before the physical examination, what is your clinical diagnosis based on history?
A respiratory cause which causes the fever. A respiratory cause which causes fever, and because of breathlessness, it can be involvement. It can be with an involvement with the lung parenchyma, other than an airway disease. Because
I will say, yeah, good. You thought good, but I will say there might be both. You know why?
Yeah.
No, sir.
There can be both. Both the parenchyma as well as the airway, both might be involved here. Yeah. See, you had a patient with TB. I will come in 2 minutes, ma'am.
Yeah.
You have a patient with TB who was on treatment. He was well compliant with the treatment, and he is having an acute issue. Started 7 days back. Fever, cough, chest pain, breathlessness. It has almost all the cardinal symptoms of respiratory system. Okay. She's having fever, so it might be an infection or a secondary infection in an already damaged lung. We don't know what is the condition of her lung right now, because when you go to the physical examination, we will understand. So she had TB. She had a might had a bad lung with a secondary infection that is indicated by the fever. Then she is having cough, chest pain. Okay, cough which is productive. So it might be a parenchymal also, because productive cough, basically it is parenchymal. Either it is a pneumonia. Okay, and there is shortness of breath and chest pain is also there. So since there is chest pain can be a pain of consolidation of pneumonia and also of effusion also is there. Okay, and in your history you told when the patient lies down to the right side, the patient the chest pain is reduced. Correct?
Yeah.
You're told like that. Fine. So
yes,
yeah. So
usually it happens
more when she lies on right.
The right side. Okay.
Okay. Increases.
So what are with the clues I have given? What all might be what are your differential diagnoses?
Like it can be like some empyema or lung abscess also. It can be.
Good. Excellent. Good. It can be a consolidation. It can be any of the complications, which can be a empyema, or it can be a lung abscess. Excellent differentiation. So you should have that idea. Okay, all your presenting complaints should point towards the diagnosis. So we have not done the physical examination right now. You have already done, and you are writing the case. So your history of presenting complaint should point towards the diagnosis you already have. I am an outsider. So from your history, what I feel is there is either a consolidation, or there might be a consolidation with an effusion, or there might be an empyema or a lung abscess. That explains all these symptoms you have talked. So you should clearly say my differential diagnosis right now are these things. Good.
Thank you, sir. Can we go to next slide? We'll go to general physical examination. In general physical examination, she was conscious, cooperative, oriented to time, place, and person, febrile. She was weak and thin build, not well nourished, and presented with pallor. No icterus was present, no cyanosis, no clubbing, no axillary or cervical lymph node was palpated, no pedal edema, no thyroid swelling, and no jugular venous engorgement in the primary survey.
This much is only okay. Then you have vitals. Okay, good. Okay. Proceed.
Vitals was she had tachycardia and it was normal rhythm and volume, no radial or no radiofemoral delay was noted. Her blood pressure was only 90 by 60
No,
on
before
right
going to
arm.
blood pressure, you complete pulse. Pulse should have many other things. Rate,
Rhythm,
volume, character, then radiofemoral delay or radial delay is there or not. Then two more things are there. Is there any vessel wall thickening? Whether the all peripheral pulses are felt, equal and bilateral. Okay,
Equal
so
and
include all
bilateral.
these things in pulse. Okay. Okay. Then
Okay,
blood pressure.
Blood pressure was 90 by 60 on right arm with adult sized cough taken on supine position. Respiratory rate was 23 per minute and temperature was normal. And
You
she
should
was
say
at
what type
Here
of
I would like,
breathing.
what type of respiration? Abdominothoracic or thoracoabdominal? You have to mention.
What is the type of breathing in females?
thoracoabdominal. I don't know, sir, clearly.
Good. Okay. In females, it is thoracoabdominal.
Can I know what is the difference between both?
Yeah,
like
it's like you should observe the respiration. In males, it will be like abdominothoracic. The abdomen will be moving more and then the thorax. Whereas in females, it is mainly thoracoabdominal. Females will breathe more from the thorax. Like the movement will be more in the thorax.
Okay, sir. Thank you, sir. Systemic examination.
Yeah, going before that. See, the general physical examination, you should frame in a, I will say my way of writing a general physical examination. This part is the introductory part. You should say that the patient is conscious, cooperative to the examination, is oriented to time, place, and person. Then the classical thing we say is well built and nourished. So built and nourishment is basically based on the height, weight, and BMI.
Yeah.
And the BMI, if there is any obesity, you should grade it. It's the normal BMI. Is it in the pre-obese stage or in the obese stage or morbid obesity? Like that staging, the WHO grading should be there. Okay.
Okay.
Then you should move to the vitals part. In vitals, you can say that was correct. Pulse, blood pressure, temperature, respiratory rate, saturation. All that 5 things should be included. Then you should go to the head to foot examination. The head to foot examination, first you should say the pickle thing, the classical things, no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or lymph node or edema. Then you should say from the head to foot examination, all the things that you see in the patient, you should say from hair to the toes. If there is any cannula, you include that. If there are any catheterized, you should the patient catheter in situ. If there is any rise tube, include that. If there is any graying of hairs, include that. Sometimes there will be some rashes anywhere, include that also. Then some tooth will be torn. Many things you can see from head to foot. You say what all you see in the examination. So include all these parts. There should be introductory part, vital part, and the head to foot examination part. And this pickle, you should be very thorough. All the differential diagnosis of clubbing, there's anemia, cyanosis, everything you should know. Because if I start questioning about all these things, the time will go on. So you should be well aware about, if you're presenting a respiratory case, you should be very aware about clubbing. Okay.
Clubbing, obviously. Esther, you mentioned about lymphadenopathy. You checked only cervical and axillary. I think in a TB case, inguinal lymphadenopathy, you should have put in mention. At least it was not there. It was there because you have to put a word for everything. What Dr. Sujit is trying to tell is an elaborate general physical examination, which every examiner would expect PGs to present. Whether it is there or not, you have to put all the points in the sequence so that it proves your case well, gives obviously that you have gone through the case thoroughly. You don't have to head to toe anything. And the salient features which have to put, there is no option of avoiding them or not putting them, because you will get stuck at the places which you have not shown. Okay. In this case, what you have, like, it's okay. We are like, you are starting presenting. That's a good effort. And I would say you have done very well so far. And regarding pickle, what he told, be thorough about the differentials, everything they will ask.
Yes, ma'am.
And BMI you have not mentioned, I think height and weight. You told thin build, but BMI.
BMI, I forgot.
No.
Systemic
And
examination.
saturations, you have written 93, 94%. You have to mention the saturation.
On
93
room air.
at room air.
Room air or
You have to
oxygen.
mention completely. Whether patient, because 93% severely breathless patient coming to you, you are putting without oxygen.
Yes, ma'am.
Start oxygen when you think of severely a young female presenting to you. So
Yes, ma'am.
any oxygen was put before examining?
No, ma'am.
No.
Oxygen was not put, ma'am.
Okay. So you have to mention saturation was on oxygen or on room air.
On room air. Okay, ma'am.
Let's proceed. Yeah.
Our systemic examination, we on the upper respiratory tract, nose is normal.
Here I would like to stop, Esther. Go to your previous slide. Okay, apart from your vitals, the last one, you haven't mentioned anything directly. You came, but you haven't mentioned a word about the eyes, the skin, whatever, hair. You haven't put a comment. What Dr.
Head-to-foot examination should be there.
Yes.
So
you have to include everything. Whether it's
Yes,
normal, you have to mention normal also. Okay.
Yes, ma'am.
And the next slide, upper respiratory tract.
As I felt it's a respiratory cause, I just came to systemic examination respiratory directly.
Okay. But where is the mention about the oral cavity? You have mentioned anything? Tongue, oral cavity, anything?
No, ma'am. Like oral examination was done along with the throat and tonsils.
Ideally, you should include that heading like upper respiratory, examination of respiratory system, then upper respiratory tract. In upper respiratory tract, ear, nose, then oral cavity. In ear, you should include that whether there is any wax, any discharge, any external auditory canal, obviously. The nose, you should include is there any DNS? Is there any infiltrable hypertrophy? Is the mucosa is normal? Then the paranasal sinuses, was there any redness or tenderness present or not? In oral cavity also, you should say oral cavity, is there any oral thrushes? Is there any bad oral? Is there any halitosis? What's the thing? Is there any tobacco stained tooth is present or not? Is there any tooth missing? Then the posterior pharyngeal wall. Then ideally you should, if you include Mallampati grading also, that well and good. Modified Mallampati grading well and good.
Mallampati scoring.
Yeah. Okay, proceed.
Yeah. So upper respiratory tract, nose was normal, no deviation, no deviated nasal septum, no flaring of Ehlers-Danlos. Throat was normal and tonsils was also normal. Engorged neck veins were present at that time of admission. Lower respiratory tract, trachea was in central, and the chest movements were symmetrical and shape of chest was normal. No infraclavicular.
Correct from here. Correct from here. The better heading would be examination of chest rather than the lower respiratory tract.
Lower respiratory tract.
Okay.
Okay. And in the upper, whatever you told till now, so far, before going directly to the chest, pulsation, engorged veins you have mentioned, but visible pulsations. Okay. Next, use of any accessory muscles, because as per your history, severely breathlessness patient
can have engorged neck veins.
Yeah. Okay. Visible pulsation, engorged veins are different.
Pulsations.
Then
pulsation was present.
Okay.
Lower respiratory tract, trachea was central, chest movements are symmetrical and shape of chest was normal. No infraclavicular or supraclavicular hollowing, and rib space hollowing was found. Nothing, it's all negative symptoms, ma'am. Intercostal retraction were present, mild subcostal retractions were also present at that time. No drooping of shoulders or no dilatation of veins or scars were noted. No pectus excavatum or carinatum was found.
We can always test in chest examination. So I'll start with the inspection first. The inspection give a detail. Then I would like to go to the palpation part. So it's a way of how we present. Obviously, you have put all the points, but examiner has to listen in a systematic way. Chest examination would like to proceed with the inspection first and then would like to do the palpation, because all the 4 points everybody knows, all the PGs they know very well. So let's move. Inspection is over for you.
Inspection is over, ma'am.
So a main point which we are missing, I think, you have not inspected the spine. In a respiratory case, chest case, spine is the most important thing you cannot miss out.
Yes, ma'am.
Do you know the importance of examining spine in a chest case, respiratory?
No. Spine,
When you see the
scoliosis,
shape,
kyphoscoliosis.
yes. So it affects a lot.
Yes, ma'am. Correct. Lung volume and
any spine
sizes,
deformity, obviously,
symmetry.
make it a mandatory point for you whenever you examine a chest, respiratory case, or any chest related case, be it cardiac or respiratory, but mostly respiratory. I think Dr. Sujit will agree with that. Spine is the important part you cannot miss out on inspection.
Yes.
Especially TB case, you should not miss a gibbous.
Yes.
Gibbous.
Because TB case you're presenting and spine is cannot be missed.
Yes.
So you have to, whether female attendant has to be there when you examine a female patient, you know the ethics, I think. We'll
Yes,
not go into detail of that. So, and in a male patient, expose fully, look from the front, from the back, from the side. It's always top. Okay.
Yes, ma'am.
Then we'll go to
In
palpation.
inspection, in inspection, you should include first the shape of chest,
Yeah.
whether it is an ellipsoid, normal ellipsoid shape or not. Then whether it is bilaterally symmetrical. Then go to the chest movements. So shape first, then movements. Whether it is bilaterally equal. We should inspect the patient from the front, back. In MacLeod's and in Hutchison, there are ways of how to examine the
Yes.
chest. So we should read that and should do in that systematic way. So first is the shape of chest, then chest movements. Then is there any accessory muscles of respiration being used? Is there intercostal narrowing or not?
Narrowing.
Then you should see the respiration, the respiratory rate and the type of respiration you can see, type of breathing you can see. Then go to trachea, apical impulse, then subcostal angle. After that, you can say, is there any dilated veins, scars, sinuses in the chest? Then you can go to the back, any spinal abnormalities present. And go in a systematic way. So
Yes.
go to the palpation part. Is there any positive finding in your inspection?
Yeah.
Sir,
Anything positive?
there was like she had a breathing difficulty. It was true. Actually, we had doubt that whether she's hysterical first, but the intercostal
Leave apart
retraction
all
and
these things. You say what you see. Have you seen anything positive in inspection findings?
Dr. Esther,
Anything
listen to
positive?
what sir is asking. He's asking positive findings on your
Any
examination.
positive findings in your
Yeah.
inspection?
Yes, mild subcostal
Retraction.
retraction.
So retractions are present. Okay, fine. Go. Then go to the palpation section.
On palpation, trachea was central. No local rise of temperature and no local tetanus over any particular ribs. Apex beat is felt at left fifth ICS, just medial to mid-clavicular line. Chest circumference was normal. And chest expansion is normal, but vocal fromitus on right inframammary area was decreased.
Okay, fine. So in palpation, you should start with the inspection findings are confirmed. Okay. Then you should say the chest movements are bilaterally equal or not. You should know how to palpate chest movements, how to find whether it is correct or not. I can demonstrate the video here. Then you should see whether the trachea is normal. Trachea can be normally deviated to which side?
When
Mild deviation to right side is
Mildly
common.
deviation.
Okay. Okay. Then you should know whether we should palpate the apex beat. Then is there an intercostal narrowing? Is there any local rise of temporis or tenderness? Then you should go to the vocal fromitus. Okay. As you have told, there is a very significant thing. The vocal fromitus is reduced in the right inframammary area. Okay, there is no auscultatory area named inframammary area in chest. What all are the areas we should check? We have
supraclavicular, infraclavicular, supramammary, pramammary,
no,
suprascapular, inter.
Axillary, infraaxillary, suprascapular, upper interscapular, lower interscapular, infrascapular. Okay. We usually won't say there is any that inframammary area is not there.
No.
So that axillary area, infraaxillary area, supraclavicular area, infraclavicular area. Okay. The vocal fremitus is reduced. What you might be meaning is the infraaxillary area is what you might be intending to. Okay, and the chest expansion is normal. Okay, good. Then you have missed one thing. You told the chest circumference was normal. What is the normal chest circumference for a 20-year-old female lady with the height of like that? You know what is the standard? You have that chart with you. How will you say it is normal?
We will.
It is better to put another. You put measurements and include what is the chest, total chest circumference, what is the circumference on the right side, what is the circumference on the left side, what is the anterior posterior diameter, and what is the transverse diameter. These all measurements should be ideally included. I don't know whether you will do.
Yes.
You should do. Yeah.
Yes.
So what is the normal anterior posterior diameter?
Yes.
Yeah. What is the normal AT by transverse diameter?
68 to 70, sir. 70.
5 by 7. Normal. AP to transverse diameter 5 to 7.
AP to transverse diameter.
Okay.
We have to mention, Dr. Esther, we cannot just write chest circumference normal. At least put the measurements to be on safe side. Of course. Yes.
So usually in palpation, it comes AP diameter and transverse diameter, no ma'am? Transverse diameter measurements, we put it in palpation.
Because inspection, you are just seeing the patient. You are not touching the patient at all. It is all your inspection. Okay, without that. Once you come to palpation, you have to confirm your inspection findings through palpation.
Okay.
Start measuring, touching the patient only on palpation.
Okay, ma'am.
Okay. Yeah.
Now we'll come to percussion. On percussion, liver dullness is felt at fifth right intercostal space, and we percussed all 9 areas of chest. In that, positive findings which we got was vocal fremitus was dull, which was woody dull or decreased over right lower chest infraaxillary area as compared to the left.
The vocal fremitus is in palpation and vocal resonance is in the
vocal resonance is in percussion part.
Okay, fine. So always start your percussion with a direct percussion on over the clavicle. The direct percussion you should say first. Okay. Then you should percuss all other areas. Supraclavicular area, infraclavicular area, mammary area, axillary area, infraaxillary area. Like that you should go. Okay.
And
I
don't think you have I'm sorry, Dr. Sujit. Is this line correct? Percussed in all 9 areas of chest. How do you mention that? You at least percuss and tell the positive findings, I think, rather than saying all the 9 percussed.
Okay. What was the percussion? What was the sound you heard? Whether it is normal resonance, hyper resonant, impaired resonant, dull note. What was the percussion sound you heard in the all 9 areas of chest?
No, in left in these areas, normal areas, it's resonance. And
normal resonance. You got some impaired resonance somewhere. Like where all you got impaired or dull resonance? Where all you got?
Left side we got dull again.
Left you got dull.
Left
you can get dullness.
Area also I got.
In the cardiac areas you can get dullness.
Yeah.
Other areas left you got also we got dullness or right only.
No, left also I got dull. Right also dull only I got.
Which area?
But I am talking about infraaxillary area. Both sides.
Area. Okay. Okay.
Bilateral. But
see,
then
see Esther. So, you know, you have a diagnosis in your head. So
Head.
all your examination findings should be in, pointing towards that, to the diagnosis.
Correct.
Okay. Otherwise, you will dig your own grave. Okay.
Yes.
So you should have the diagnosis in your mind and then tell accordingly. Yeah, the vocal resonance is in oscillation. Sorry, I wrongly told it in percussion.
Yes, sir. Vocal
Somebody has come in.
resonance. On
Yeah, yeah.
oscillation.
So what was your percussion findings? Tell once more. Left side.
Percussion findings. Positive findings which I got was only right side. It was woody dull, sir.
Okay. Where on? Which all area?
In only one area, in infraxillary area.
Infraxillary area. Infrascapular area you didn't get.
No.
Only in infraxillary area.
Area.
Okay. Good. Okay. Then did you do a tidal percussion? What is tidal percussion?
Tidal percussion is actually when we inspire tidal percussion, we will percuss from the top to bottom. And when we reach the solid organs, we will have a dullness. And when we inspire and again we will percuss, there will be a shift.
Okay. So when we tell the patient to inspire, if you're getting normal resonant sound, what does it mean? The pathology is?
Sir, I didn't get you.
Suppose you started percussing in the posterior area. Okay, you got dullness. You tell the patient to inspire. Okay. You're getting resonant node there. What does it mean? Normal resonant node there.
Hyperresonance means pneumo, air.
No.
What sir is asking, something is there which is causing you dullness, which has during inspiration has gone
down. So it is diaphragmatic dullness. Okay. If despite inspiration, if you're getting dullness, what does it mean? If you told the patient to inspire, okay. Again, in the same area you are percussing, if you're getting dullness, what does it mean?
The pathology is from the lung itself, not
the
from
pathology
the...
is above the diaphragm. The pathology is above the diaphragm. Okay,
diaphragm.
Good. Okay, good. Then what all other percussion you should do? Liver dullness you should do. Then drop space should you should percuss. Then chronic isthmus also you should know all these areas. What is chronic isthmus? What are the boundaries? Then what is the drop space? What are the boundaries of drop space? Liver dullness, where all you will get? Okay. What percussion sound you will get in drop space?
Dullness or
if you have read, you will answer. Otherwise, read these
more.
spaces.
Okay. You read
What
more
sir is
on this
telling
examination of respiratory system. Okay. Okay, fine. So move forward. So you got dullness in the infraaxillary area. Okay, good. Okay. Go to the auscultation.
On auscultation, normal vesicular breath sounds was felt on the left, but fine crepitations and crackles were present at the inframammary area on the right.
There is no area known as inframammary area. So you should not comment. There is no area named the inframammary area. Okay, in standard textbooks give.
It's infraaxillary area.
Infraaxillary area or mammary area?
You didn't get anything infrascapular.
No, ma'am. Actually, I must have missed it.
Okay.
You got
it is found,
okay. Tell. Yeah.
It is found to be more and this crackles and crepitation was found to be more clear on auscultation while coughing.
Okay, good. So see, in auscultation, you should say the breath sound. Was it normal? Don't use the term normal vesicular breath sounds. Okay, it is an old concept that the breath sounds, basically what we hear is because of the sound in the alveoli. No, it's not the sound in the alveoli. We are basically getting the sound in the larger airways, which is basically attenuated by the lung parenchyma. So you should not use normal vesicular breath sounds, use normal breath sounds only. Okay, that's now outdated. So standard examination might say don't use the term vesicular. It's normal blood sounds is enough. Okay. What are the
Okay.
abnormal blood sounds? You know.
Abnormal breath sounds.
Abnormal breath sounds. You know.
Sounds.
Abnormal breath sounds, bronchi, wheeze, crepitations,
Bronchi, wheeze are
crackles,
additional sound, added sounds.
added sounds.
The bronchi, wheeze, crepitations, all are
Are
added
added
sounds. What is
sounds.
bronchial breath sounds?
Bronchial breath sounds we can hear from the bronchioles and the main bronchus.
Okay, correct. But if you get a bronchial breath sound auscultating in the infraaxillary area, what does it mean?
Means the airway is having the pathology, and parenchyma is having the pathology.
Why? And you are getting the bronchial breath sounds directly if you auscultate in anywhere the chest. It means that the lung underlying that area is solidified so that the sound from the bronchi is directly transmitted to the lung, the chest surface. So it means that there is consolidation. The most common diagnosis that we get in a bronchial breath sounds is consolidation.
Consolidation.
Okay. Okay. You didn't get any addition. You got some added sounds in the inframammary area. What you felt is mammary area, right? Mammary area you are getting fine crepitations and crepitations you are getting. Then there is dull knot in the dull percussion in the infraaxillary area. Okay, and what is a vocal resonance?
Okay. Vocal resonance. Sir,
what is a vocal resonance? Did you do vocal resonance?
Vocal resonance.
Did you ask it to speak something and then
can't auscultate?
You didn't do vocal resonance is also part of auscultation. Okay, in auscultation you should know the breath sounds. Is there any additional added sounds? Then you should know whether there is any what is a vocal resonance in each area. Okay, and the vocal resonance should go with the same finding as vocal fremitus. Otherwise, you will be contradicting yourself. Okay, so since your vocal fremitus was decreased, was reduced in the right infraaxillary area, your vocal resonance should be also impaired or reduced in the impaired in the right infraaxillary area. Okay, good.
Okay, sir.
Good. Go further.
Okay.
Till what time we have this class? Till what time?
Actually,
you can go on for another 15-20 minutes. You can go on.
Yeah,
okay,
15-20 minutes.
Yeah.
We can.
So move fast.
Okay, sir. And in CVS part, we had a short examination only, and in that we had no significant findings, sir. Systemic examination.
But Esther, I'll not take much time, but CVS also you have to mention at least the basic points. S1,
Yes,
okay, but
yes,
apex speed you have already mentioned, but still it makes sense to write it here also. JVP pulsations, everything is okay. Carotid pulsation, if you can mention, you have already mentioned, I think, in the GP. So apex speed is there. Okay. Next.
Okay. And per abdomen also, we didn't have any significant findings. Soft abdomen without significant splenomegaly or hepatomegaly was also not found. All quadrants of the abdomen was soft and no tenderness was felt in any quadrants of the abdomen. In CNS examination, like she was already we said she was conscious oriented, higher mental functions were normal, no neck rigidity, no signs of any meningeal irritation.
So we'll move. If everything is not significant, you can move on. Yeah.
Good. Okay, you have included the summary of each system after respiratory examination. Good. Okay. You don't summarize this much. You summarize your clinical examination part. Okay. The history examination you summarized, and we have come to some differential diagnosis. Now you tell the positive findings you got in your clinical examination.
After the primary survey, this young girl on ATT had right-sided crepitation on auscultation, and on percussion at right infraaxillary region, she had dull notes, which can be a consolidation collapse.
Go in the order. Go. Tell the positive findings in general physical examination, inspection, palpation, percussion, auscultation. Don't directly jump to the auscultation part. Okay. General examination, did you get any positive finding?
In general examination, she
She
had
was
just
not
a
febrile.
pallor.
Okay. So she
Pallor.
had just a pallor. Okay, good. Then
In inspection part, nothing was significant.
some retractions were seen.
Retractions only
because
were
of
there.
breathlessness. Okay, okay. Fine.
And in palpation part, we got a right side dullness in infraxillary area.
Palpation, you got vocal
Vocal
fremitus.
fremitus.
Okay, reduced
Vocal
vocal fremitus.
Fremitus.
Vocal
And
fremitus in the intraocular area. Okay.
And in auscultation also vocal resonance and crackles are also was
there
there
in the mammary area. Okay. Yep. Okay. So with the clinical, with the I forgot to tell in auscultation, you should know what is normal breath sounds, what is the mechanism of normal breath sounds, what are the abnormal breath sounds. Okay, bronchial breathing, what are the type of bronchial breathing, you should know. What is cavernous breathing, what is amphoric breathing, everything you should know. Added sounds, crepitations, what are the differential diagnosis of crepitation, what are the differential diagnosis of ronque or wheezing. Okay, all these things should be, you should know very well. Okay, I'm not going to ask that question because it will drag the time. Okay, yeah. Good. So now we have got the positive points and you come to the diagnosis based on your clinical examination. What might have caused given this clinical examination? Before that, I need to know, give me some differential diagnosis of crepitations.
Sir, crepitations, crackles and rails, most commonly we see in like any kind of subacute parenchymal infections of the lung. Like it can be, most commonly crepitations are seen in TB only, sir.
Tell me conditions. Okay, you are getting, I will give you clue. Bilateral infraaxillary, bibasal crepitations. What are your diagnosis, differential diagnosis? Actually, crepitations, you should like early inspiratory, mid inspiratory, late inspiratory, there are multiple prospects are there. So I don't want to divide each and drag the time. So just broadly you say, bibasal crepitation, what are your diagnoses?
Like lobar pneumonias?
No, lobar pneumonia is a focal area. If you're getting bibasal crepitation, tell me two differential diagnoses which will come to your mind.
Bibasal crepitations.
Only two. You know what is interstitial lung disease?
Interstitial lung disease.
Okay, you know what is pulmonary edema? What will we get in pulmonary edema?
Pulmonary edema. Pulmonary edema of cardiac and non-cardiac causes can be having.
Then what are other differential diagnoses? What is bronchiectasis?
Bronchiectasis also we can have crepitations.
Good. So okay, in this patient we are having a focal crepitation in the right mammary area. So what it might be?
As I said, like it's only to the right side of the lung. It's in one lobe only, so it can be one side. Only one lobe is involved. So it is a local. It can be a local cause, or it can be in TB usually.
Okay, fine. No. Yeah, fine. Don't go with TB.
What, Dr.
I just want to. I want to get the answer from you. That's why I'm giving you clues. Okay, with the clinical, this signs.
Actually, she has seen the case, she knows the diagnosis, and then they present. So it's a difficult thing. They already have everything in mind, and they go towards that thing without ruling out other causes, differentials.
Yeah, TB is not a diagnosis, clinical diagnosis at all. Okay, tuberculosis is basically a pathological diagnosis.
Pathological diagnosis.
Okay, or etiological diagnosis we can do.
What your patient present after TB? Fever?
Let's see one thing. What is your diagnosis now? So you have come to the end of your discussion. So what is your diagnosis now? Tell me the diagnosis. Leave that for the summary.
Like she is already an immunocompromised host. So she can have a normal like pneumonia, viral, bacterial or fungal causes. Other than that, she can have this hilar lymph node related any local infection and.
See, you cannot say she's having an immunocompromised. She is basically having TB. That's all. What is the immunocompromised? Is she diabetic? Is she having any immunodeficiency syndromes? Nothing is there. She's having TB.
Actually, this
She's having,
dullness,
you can say there's some structural lung disease because of TB. Might have occurred. Okay. You cannot say it's an immunocompromised state.
like dullness will point out mainly to pleural effusion. But
okay, good. Okay, pleural effusion is there. Okay. Then what does the Krebs? What does the Krebs means?
Krebs is actually
A focal
like,
crepitation, the right, what do you say, the mammary area? But what it might be? What is index crepitations?
index
It's somewhere
crepitations.
beyond. You go and read all these things. In the early phase of consolidation or the late phase of consolidation, when the secretions are getting cleared, you can get crepitations. Ideally, if the patient was in the stage of pure consolidation, in the red hepatization or the gray hepatization stage, you would have got bronchial breath sounds. You didn't get any bronchial breath sounds. I don't know if I did not examine the patient. So if I got bronchial breath sounds, I could say it's consolidation. It would definitely consolidation.
Correct.
And there should be, I would do egophony and bronchophony. That also will be elevated, increased. And here you got crepitation. So crepitations is there. It might be an index crepitation or the consolidation, the what do you say, the relieving phase or the resolution stage of pneumonia. You will get crepitation. So I will say you had there, the patient might have had a right middle lobe pneumonia or a right, basically right middle lobe. If you get in the mammary area, it will be middle lobe. So right middle lobe pneumonia with effusion, with a sympneumonic effusion, because the infraaxillary area, you got dullness, the vocal fremitus and vocal resonance is reduced. So if I was answering, I would have told, sir, this might be a case of right middle lobe consolidation with effusion, sympneumonic effusion, probably secondary to TB, tuberculosis. So your diagnosis should have three parts: anatomical diagnosis, pathological diagnosis, etiological diagnosis, and you can also include complication part. If suppose the patient is in respiratory failure, if the patient is needing oxygen therapy, or if the peripheries are marked, or the patient is breathless, you can say it is there is type 1 respiratory failure, is type 1 respiratory failure. If there is any pedal edema, if there is any bounding pulse, if there is any is there any hepatojugular reflex, bibasal crepitation, you can have core pulmonale or cardiac failure, such complications is there. So you should have an anatomical diagnosis, pathological diagnosis, etiological diagnosis. That's how you should conclude a diagnosis.
These are like in this summarized part, I just went through like how much differential diagnosis I can go through, that I have written, sir.
Actually, Dr. Esther, what Dr. Sujit told, a diagnosis made on the points based, anatomical, pathological, etiological, and complication. There is no need for explanation of this. This is for the examiner. They will ask you, then they will start asking you. You made, how did you go about it? Why did you find this? Why didn't you find this? What were your conclusion? Because at every point of examination, they will ask you DDs for everything. What he is trying to say, how, when you find Krebs, what are the conditions usually you find Krebs? When you find bronchial breathing, when you find so much. So these are the points we have to learn and see while examining. When you examine lots of patients, you will come to know, and through experience, you will definitely be expert while doing that.
Okay.
So we have to, with the history, with the given conditions, you have to rule out and come to a point, to a certain diagnosis at the end. Correct? Okay.
Yes,
yeah, Esther, don't worry. This is not your final examination.
Yeah,
you are hardly 5 or 6 months into your. You have 2.5 years left.
Very happy,
so,
sir.
You
this is an introduction only.
Yeah, you have made a really
done a good job. Okay.
Yeah.
Yes,
good effort, good job. Yeah.
So this was our provisional diagnosis: pneumonia involving right middle and lower lobe in immunocompromised.
Why I didn't say lower lobe?
Because we didn't get in the back.
Yeah, infraaxillary area, infrascapular area.
Scapular area. You have not mentioned anything in your findings.
Lower
infraaxillary area is the area where the pathology involved all the segments. But you didn't. You told your infrascapular area was a normal, totally normal. So I cannot say it's lower lobe.
No, lower.
Okay.
And I think, don't think this word is right, immunocompromised host. We should not.
It's not. We should not use. If
Uh,
the patient is having HIV
can
or on
always
chronic
tell.
steroid therapy
Yes.
or anything related to the immunocompromised,
Related.
okay.
Correct. Until unless you have a proven diagnosis or you have history of something, you should not mention. You can always write it, patient known case of tuberculosis, definitely, on ATT with so-and-so diagnosis. That you can mention. That makes your complete diagnosis.
Okay, ma'am.
Include all these factors that is
Yes.
on everything.
That was nice.
Yeah. I will conclude this case. Okay, I will conclude how I answer. Yeah, a 20-year-old female with passes with family history of tuberculosis in father, and was diagnosed tuberculosis 6 months back, who is in the late continuous phase, means in the hardly 5 days left. Okay.
Yes.
In the last phase of the continuation phase, presented with the fever of 7 days duration, cough, restlessness and chest pain of 3 days duration, with the clinical features of anemia. There are subcostal retractions.
Yes.
Then vocal fremitus and vocal resonance reduced, mid capitations.
Yes.
So my diagnosis is right middle of pneumonia with the effusion, pneumonic effusion, and see, if in typical respiratory system examination, if it is a purely respiratory resident, we would have gone in many other ways. Whether we have done shifting dullness was done or not, all these related to. There are many other spaces in chest. All these named spaces, multiple type of percussions are there. So I'm not going in such things. If you are interested, you can go and read. Many Indian authors are there.
Yes. Dr. Sujit, it is mandatory for us to do that also, because they usually ask. And if it's not related, also the examiner would ask just to know that whether we know the clinical examination part thoroughly or not. So we have to examine this. Shifting and spine, as I told, my examiner was always like, wherever I did when I did my DNB, they were thorough with the spine. Don't miss spine in a chest examination. You remember that. Inspection, palpation, both. And that to a TB case you are presenting, you cannot forget spine to be examined.
Yes, ma'am. Thank you, ma'am.
Okay.
It's going to finish.
Yeah.
Yes. Dr. Vishnu, do you want to wrap up?
Just want to know whether the discussion part is, I mean, with the management part, if anything is being discussed. Sujit,
Actually, if we go with the management, we can talk another 1 hour. Okay.
Yeah.
So I will say a few questions. Just write down the questions and read. Okay. Yeah. So you should be well aware about the NTP guidelines. Go and read NTP guidelines. At least the drug-sensitive regimen you should know. Okay. Then
she has included in the slides. The algorithm is she has included in the slides. It's
okay. Yeah. We include that everything. What is presumptive TB?
Yeah.
What I will tell a few questions. What is presumptive TB? Okay, what is the dose of each drug for if we give the weight? What is FDC? What is fixed dose combination? How many fixed dose combination for which weight group? Okay. What are the individual drugs you should know? What are the complications of rifampicin? What are the adverse effects of each drug you should know? So how will you follow up a patient with TB? Yes. Okay, how will you diagnose TB? Okay, what are the sputum microscopy? What are the newer methods of diagnosis of TB? What is CB NAT? What is true NAT? Okay, what is LPA? What is drug-resistant TB? What is MDR TB? What is HDR TB? What are the newer drugs in the treatment of MDR TB? So multiple questions are there. You should be well aware about TB. And regarding consolidation, there are many other questions are up. So if I go, I will talk for 1 hour. Okay.
It's a very deep, because we haven't reached to the investigation part yet. The basic investigation done at PHC level and the tertiary care center is totally different. We don't have facilities at the PHC where your patient came. We didn't have the facility for CBNAT also. There was no facility even for ESR. ESR was not. Is a main investigation for a team. MEN2 test was not done. I think MEN2 they did or not, we don't know. You haven't mentioned it anywhere.
No, man, two
What
was
is
done.
so
ma'am.
now the India government is towards latent TB treatment. So you should know about latent TB. So what is latent? There is no term not latent TB. It's now tuberculosis infection. So TB infection. What is TB infection? What is the definition? How will you treat a patient? They will be asking. You are diagnosed a patient with TB. They will ask, did you counsel the patient attenders to get tested? Did you test the patient's that patient's other siblings?
Family
Did you test the
members.
patient's family members were tested or not? So how will you treat? How will you diagnose latent TB infection? What are the methods to diagnose? All questions will come up. What are the treatment regimen for latent TB infection? Write these questions and find the answers. Okay.
Okay.
So what is TB gold? Okay. What is rifampin? What is the new drug in the treatment of latent TB infection? Okay, you know, if the answer will go on. I just told few questions.
Okay.
You can write all these questions and whatever doctor is telling, you just write
and
it.
read all this. You should
Read
be well
all
aware of TB. Being an Indian, whichever specialty you are, you should know what is TB, what are the drug, because EPTB is very common. Now the pulmonary TB is almost coming down. It's the time of extrapulmonary TB. So all the surgeons, all people should know what is TB. So you should be well aware about TB. Being a physician in India, you should be well, from A to Z of TB, you should know.
Yes, ma'am. Yes.
Esther, I would like to suggest go through Hutchinson, McLeod in detail. Hutchinson and McLeod, I would prefer. They are given excellent, beautiful examinations. So you can go through.
Yes.
Dr. Sujit, if you could give those 15, 20, 25 salient questions, we can share it as a group for people to know that as an anyway, you know, like minimum basic, those should be. So that will help even those who have not joined today and, you know, when they revise for the exam.
I will give it to Dr. Vishnu.
Yes, that will be great. Dr. Priya, even if you have anything that you want to add on.
Sure. I can always, I told Dr. Esther, if anything, any presentation, case presentation, they can always ask for my help. I'm always ready to help.
Yes. Yes, now we will start.
Okay, sure.
Ma'am, actually, I want to do good presentation. Like, I'm trying my best.
No, you did a great job. Yeah.
You are a first year resident, hardly 3 or 4 months into the specialty. That you have done excellent. Okay.
And without any guide and supervision.
Nothing at
so
all.
that was
Exactly.
excellent.
Thank you, sir.
All the best to you, Esther. Thank you, everyone. Yeah.
Before we quickly wrap up, we have Dr. Raman. He has joined us today. Sir, welcome to the session. If you want to say a few words, sir. We also have Dr. Mohan with us and Dr. Resmi.
Hello.
Yes, ma'am.
Hello.
Hello.
Yeah. This was an excellent exam-oriented case presentation. I would say the time allotted was much less, so that management part and all could not be discussed in detail. But I think we can have, if such a case is being discussed, I think why don't we have 2 sessions or something as a continuation of this, the management part only, or something like that. If both the presenter and the moderators are willing for another session. I'm not telling about this, but in general, when there is such long discussions which are beneficial for the PGs happen, and as I understand, the DFM students are mostly without any guidance. So why don't we give them a chance to go to the management part also? To the, I mean, why can't we have 2 sessions?
Part 2.
Maybe 2 or 3 days apart or a week apart, so that the whole case is being covered comprehensively.
Vishnu, we can try that. Maybe next week, choose a date and
management presentation.
Yeah.
I think Raman sir is not able to unmute.
He's unmuted. He's unmuted. Sir.
May I say something?
Yes, sir. Yes, sir. You can.
Okay, firstly, compliments to Spice Route Rajasthan for their first ever event. I think this is the first event from Rajasthan. I mean, congratulations to Rajasthan team. It was an excellent presentation. I think I must compliment the presenter firstly, Dr. Esther. I mean, she was so bold and brave in taking up this case. And what I liked about her is that she was so composed in spite of the examiner and the moderator posing, poking her, but she kept her cool and she was so forthcoming in accepting that she does not know if she didn't know. That was really good. Very well done, Dr. Esther, firstly.
Thank you, sir.
And compliments to moderators, Dr. Priya and the expert, Dr. Sujit. It was really very well conducted event. I mean, I'm pretty sure that the residents will be immensely benefited with such kind of case discussions. This just reminded me of, I was always very fond of respiratory case. I used to always pray that I should get a respiratory case in my final exam. And it just reminded me of how we were grilled by those days examiners used to grill us and ultimately they used to bring out the diagnoses and all the clinical thing. And I think you both did an excellent job. Thanks. And I just want to mention that these things, these kind of presentations, we are going to have in greater numbers, more frequently, probably in state-wise. I think we have had discussion with the Spice Route, and Spice Route probably will be coming up with something exclusive for the PG residents. We'll announce it probably in a couple of days. Spice Route will be coordinating that, and they'll be leading these academic events which are PG oriented towards diploma students. This request had come from the diploma students. They were saying that many of the places, they don't have faculty, they don't know how, they don't follow the curriculum. So we thought probably we must help as an academy to fill these gaps in training in many institutes. So we will announce probably in a couple of days about what is going to come up for PGs. Thanks for the opportunity. I really enjoyed being part of this discussion, although we were all unmuted, but I was just, the listening itself was so enriching. Thank you.
Thank you, Raman sir. Yes.
I think
Thank
Raman
you.
sir is.
Are you listening me?
Yes, sir. We can hear you.
So thank you, Raman sir. Congratulations and thank you so much. And you encourage us and coming in this platform. And I want to tell to all of you, Raman sir always inspired me and always helped me to pass DNB exam as well as theory as well as practical. So my request to Raman sir, under your guidance, we want to had a national conference in Rajasthan after a few months. So definitely we'll give you a program list and most welcome come in Rajasthan and with these students. So thank you all.
Raman sir, we can hear from you.
Thank you all. Thank you for inviting me to this CME. I wish we had similar opportunities when we were residents, trainees. Thank God to the development of IT and the facilities. And now we have, and you know, when such events happen, people from all over India can benefit from it. So now there are more seats. We are expecting, you know, in coming few years, more and more seats, diploma as well as DNB and MD's programs also opening up more and more. So more and more residents across India will benefit from uniform training and peer learning, discussing from each others and case discussions like this. Very helpful, not only from academic point of view of being trainee and passing examinations, but also as part of lifelong learning as family physicians or family medicine experts, specialists. because these are the cases when you come in practice and you when you practice on your own, or you know, whatever capacity you pursue your career, you have to be a clinician as a family medicine expert. So this will benefit not just for passing examination, but also lifelong in pursuing your own profession. So a wonderful, well done, Spice Route, AFPI, Rajasthan. I compliment and congratulate the speaker, presenter, moderators, and organizers for this wonderful event. And it's every time I attend such meetings of young doctors, I find myself inspired. So thank you all very much.
Thank you, sir. Yes, Vishnu, we can wrap up.
Just want to thank Esther for bringing up with a good presentation, and all the moderators, Dr. Priya and Dr. Sujit, for having a wonderful discussion. And I would also like to thank the senior members of the AFPI, Mohan sir, Rashmina, and all other senior members, Dr. Arun, President of AFPI Rajasthan, and all the attendees. We had around 60 odd participants attending the sessions. We hope to have more number of PGs attending future sessions. So I think we can plan the continuation session of this in a short span, which will be updated to all of you. So that we can wind up the sessions. And
Thank you for giving me an opportunity, AFPI and Spice Route. Thank you.
Thank you, Dr. Sujit.
Thank you, everyone.
Thank you, everyone. Good night.
All very good discussion. Keep continue.
Thank you. Bye-bye.
Thank you. Bye-bye.